What we have in here is essentially Medtronic is a huge company that provides us in pain management with several techniques that are very helpful. So essentially, let's start by just talking a little bit about chronic pain. Chronic pain is any kind of pain that has been there either constantly or intermittently for longer than 3 months. All right, so that qualifies as chronic pain. Within chronic pain, you have your non-malignant pain and you have your malignant pain. Malignant being any kind of pain that comes or is associated with cancer. Non-malignant being the ones that you have, such as postherpetic neuralgias, herniated disc, radiculopathies, fibromyalgias, all those things, right? So within that, we also further classify it into nociceptive types of pain and neuropathic type of pain. And I'm going to make this very simple. Nociceptive type of pain would be the kind that you have from your joints, muscle, stuff of that nature, while neuropathic is more the type of pain that you get when you have a nerve that it's pinched or irritated or inflamed, as it's the case in the shingles or the postherpetic neuralgia that you can get afterwards. Chronic pain, definitely, as we all know, can have a significant impact in life. It can cause anxiety, depression, it can increase stress, and the other way around also works the same. Stress can increase pain, it can cause financial hardship and lack of sleep. Some of these things we have been able to document that there are actual changes in chemicals in the body that go along with it. Like, for example, the combination of pain and depression. There have been studies that have shown that patients who have chronic pain tend to have low levels of serotonin, which is something that is shared by patients that also have depression. So it's not surprising then to know that somebody with chronic pain may also suffer from depression. In fact, we kind of expect that. So I would say that probably 90% of the patients that we see with chronic pain will have some degree of depression. All right, so the patients, what happens to those patients when they start with the chronic pain? Normally, it goes through to their primary care physician first, try to figure out what's happening, what's causing this pain. If it's normally the primary care physician can tell if it's something that's urgent, that needs surgery, like for example, if you have an appendicitis. That you wouldn't need a chronic pain specialist for that, where you need a surgeon. And again, the primary care physician can determine that. Let's assume for a second that this is something that has been there for a while now. It's getting into the category of chronic pain, those 3 months. And now the primary care physician wants to know, okay, what would be the next step? And of course, it all depends on what is causing the pain. If we're talking about, for example, low back pain, okay, there are many causes of that. Typically, you would have some X-rays. If the pain is also going down the leg, it'd be helpful to have MRIs again to find out if you're dealing with a herniated disc, or if it's just something that it's irritated the nerve and you don't really need surgery for. That's where the MRI comes in. X-ray versus MRI. The X-ray show you bones, while the MRI shows you soft tissue. Soft tissue would be things like your discs. All right. The MRI is also very helpful in looking at certain things that the X-ray cannot look at. Like, for example, the X-rays, we normally can look at somebody's spine either through the anteroposterior view or lateral views, or we can also do oblique views. But what will not happen is that you cannot see through the inside of that spine. Okay, that's where the MRI or CT scan may come in. All right. Now, assuming that you do have some problems with your back, they may decide to go first with some physical therapy, look at some rehabilitation specialists, especially if you've had some kind of surgery. When you're having go more into the long term and it is affecting, causing problems with depression, your ability to work, so on, maybe getting a psychologist involved may be helpful. Remember that it's not just that pain causes stress, but stress itself can make pain worse. So getting a psychologist to essentially deal with that part can help you in decreasing some of your pain. If all of that fails, or somewhere in there, you want to get your pain specialist. And what we offer to the community, it depends, again, on what the problem is. If it's a problem with the spine that we've determined that may have something to do with swelling, well, epidural steroid injections may be wonderful for that. If it's something more mechanical, we can also help you determine that and essentially guide you in the right direction towards a surgeon if that's what's needed. Okay. Now, normally, especially nowadays with the issues of healthcare, what they want us is to follow certain guidelines. And these guidelines, essentially what they involve is following this step ladder, where you start with conservative therapy. Okay, that would be your physical therapy, rest, that kind of thing. Then you may follow with medications, interventional treatments, implantable, and surgical. Conservative therapies, you have your non-medical, okay, your massage therapy, ice, heat, relaxation techniques, yoga, reflexology, exercise regimen, acupuncture. Medical, you may have, and this is provided usually by a medical psychologist. That would be your biofeedback. Physical therapy by your physical therapist. Chiropractic therapy, and TENS unit, which is a little electrical device that you can put on the skin, turn on, and you feel like a soothing, tingling sensation that helps relax the muscles. Now, if the pain continues, or to assist with the conservative therapy, you can also start going into some medications. Of course, we like to try first things like your over-the-counter medications, your muscle relaxants, your non-steroidal anti-inflammatory drugs. But of course, the problem here is that not everybody can take those. Okay, non-steroidal anti-inflammatory drugs, things like Motrin and so on. The issue there is that some patients may have certain contraindications to that. Renal failure, problems with ulcers, if you're taking Coumadin or some kind of blood thinner, since one of the possible side effects of those non-steroidals is that it can cause you to have, or it can lead to some ulcers. If you start bleeding and you're on a blood thinner, that can be bad news. Okay, muscle relaxants. Some of the most simple muscle relaxants out there are magnesium. You can get over the counter. Magnesium is a wonderful muscle relaxant. And of course, if the over-the-counter medications fail, then you can get similar medications that are prescribed. There are prescription strength ibuprofen, which would be your 800 milligram ibuprofen. There are muscle relaxants such as Flexeril, Robaxin, Norflex, all those. And those usually you want to use them when there is a component of the pain that you've assessed that it's coming from the muscle. The non-steroidals, you want to use those when you think that there is some issue with swelling or issues with problems in the joints. Antidepressants. As I said, the antidepressants, what they do is they can help bring up the levels of serotonin. As you recall, I told you that the serotonin is low on patients that have chronic pain and also on patients that have depression. Now, that's not the only thing about serotonin. The interesting thing about serotonin is that serotonin allows you to tolerate more pain. So if your serotonin levels are low, you tend to perceive more pain. So this is how we use the antidepressants, by increasing those levels of serotonin, which in turn help you tolerate more. All right. Anti-seizure medication. Now we're going into actually changing that. We no longer are calling those anti-seizure medications. We're calling them more membrane stabilizers. These are your Neurontin, Lyrica, and essentially what they do, if you think of pain as an abnormal firing of a nerve, and you think that things like seizures or epilepsy, it's also an abnormal firing of nerve. The difference is that when you have seizures, it's happening in the inside of the brain, central system. So when you have and you give this patients this kind of medication, what it does is it basically lowers the ability of that nerve to fire at random. And therefore, it's very helpful on those patients that come in and tell me that they're having sharp shooting pains that are electrical-like in sensation. Those benefit a lot with that. Of course, also neuropathic types of pain, like the burning kind of sensation, they do extremely well with the membrane stabilizer or anti-seizure medications. Of course, we got steroids. We don't like to put anybody on steroids all the time, but it's very appropriate and it's a simple thing to do when you have a quick problem where there is some inflammation and you're having, for example, pain going down the leg, and it's mimicking a radiculopathy, and you want to find out if what we're having here is just some swelling of the nerve, or if it's an issue of the nerve being compressed. Steroids would be a good choice there. You give them the steroids, if it's swelling, you should see some benefit within a couple of days. And of course, the opioids. The opioids is what we all try to stay away from. Above all, is because of the problems that we've had with their regulations, where they're highly regulated. A clinic like mine, where we do prescribe this kind of medication, we're constantly under the scrutiny of things like the State Bureau of Investigation, DEA, all those things. And they want to make sure that we document everything right. And so what does that translate to the patient? It's a pain in the butt for you guys. Okay? Why? Because you get all this long questionnaires, and we're constantly having to do drug testing and all those things. The issue is that we're required to do that. If we don't do that, then we get into trouble. Okay? And of course, there are some other things like patches. And the patches, remember that when you hear that somebody has a patch and they're doing really good, keep in mind that there are different kinds of patches. A patch is just a way of delivering a medication. So you have patches that are like Duragesic, which is a narcotic. Then there are Flector patches, which are essentially a non-steroidal anti-inflammatory drug. Or you have lidoderm patches. Lidoderm patches are simply a numbing medicine. All right? So you have different kind of patches, and they all have their own use. And you have creams, and this is essentially, creams are another way of delivering medicine to your system. All right? All right. So you've had all that done, and you're still having some problems. So now we need to figure out what else can we do. Well, this is where the interventional pain management comes in. That's what I am. I am a board-certified interventional pain specialist, and I did my training at Bowman Gray. And after I finished my training, I was invited to stay there as a teaching physician. So I did that for a couple of years, and then I moved on to private practice. All right. Now, within interventional pain management, we have that we use all of our injections in several ways. Each injection that I do, I try to look for both. I try to use them as diagnostic tools as well as therapies for the pain. Let me give you an example. An epidural steroid injection. When we do an epidural steroid injection, we'll put in there a local anesthetic and a steroid. Why? How does each one of those things fit in? Well, the local anesthetic, what it will do is it will numb the area where I've injected the medicine. So the first thing it does, if you think about it for a second, is if I inject it in the right spot, it should get it numb, and the pain should go away if the pain is coming from that area. So that's how it works as a diagnostic tool. Okay. I inject the medicine in the area, your pain goes away for the duration of that local anesthetic. Bingo, we were in the right spot. All right? Now, the next thing is follow up and see what happens with the steroid. Okay? The steroid, it can take anywhere from 4 to 10 days to take effect. How long does it take to take effect? It depends pretty much on how much swelling there is. The less swelling there is, the quicker you'll get your benefit. The more swelling there is, the longer it'll take for you to get that benefit and to feel the effects. All right? And of course, if you take into consideration those two things, then you'll notice that there are several combinations that you can have. You can have that after a procedure, when you see the patient back, they can tell you, well, I had 100% relief of the pain, okay, for those initial 4 to 6 hours, and I had great relief with the steroid. So from that one, I learned that I was in the right spot, and that yes, when we're dealing with something that has to do with swelling. Another possibility. How about the patient that comes in and says, I had 100% relief of the pain for those initial 4 to 6 hours, but I didn't get any long-term benefit. Okay, that tells me that I am in the right spot, but what we're dealing with has nothing to do with swelling. Okay, that is more of a mechanical problem. Now, there's also the possibility that it could be that there's more swelling that one treatment alone can handle. But that's where the expertise of your pain specialist comes in and try to differentiate those things. Another possibility, patient comes in and says, I had no benefit whatsoever for the initial 4 to 6 hours. But you know what? 4 to 6 days later, I got 100% relief. Well, what happens there is, no, I was not in the right spot. That's not where the pain's coming from. But guess what? It does have something to do with swelling. And so it did help from the systemic effect of the steroid. All right? And of course, there's the case where you don't get any short-term relief or long-term relief. You're not in the right spot, and probably there's not much swelling to be to speak of there. All right? And so that's how we interpret things when it comes to the diagnostic part. The one thing that really kills me is if we do this, we always want you to come back so that we can interpret this information. If you have the injection and then you don't come back, you're going to miss so much from what we can tell what's going on that ultimately can help you. That, you know, it's sad. And of course, then there is the other side of the coin. Then there are some, not everybody out there doing this kind of injections is an interventional pain specialist. There are some people that will get you in, do an injection, and not even see you back. To me, those guys shouldn't be doing this. Okay? Because you have to be following the patient and see what happens. All right. And of course, within interventional stuff, as I said, we talked about diagnostic, therapeutic, and then there's destructive. What is this? Okay, what that is your patients that have cancer. Let's take, for example, the patient with pancreatic cancer. Okay, we go in, we do a celiac plexus block with local anesthetic. We get good results, but no long-term benefit. And this is related to the cancer. We can come back and repeat that same block, but instead of using local anesthetic, then we'll use a destructive medication, such as alcohol or phenol. And that will give the patient longer lasting relief. This is what used to be called the permanent blocks. Of course, they were permanent for those patients because the block would normally outlive the patient's lifespan or outlast the patient's lifespan. Of course, if you try to do this on somebody that doesn't have cancer, what you'll see is that they will wear off eventually because your body's going to heal and it's going to go back to normal. And of course, you know, nerve blocks. I see a lot of people that come to my practice and I ask them, have you ever had anything done for your pain? They say, yeah, I have had some nerve blocks, but they can't tell me exactly what kind. Always try to have your physician write down for you what kind of injection they did. Because when we talk about nerve blocks, this is just basically like saying surgery. There's thousands of different kinds of surgeries, and so there are also thousands of different kinds of nerve blocks. And each one has its purpose. Okay? And so here, neuroablation refers also to this. It's another type of destructive technique, but this one we use more with non-cancer pain patients. So this would be more your radiofrequencies. Radiofrequency is a technique where you can go in there, and if you've done a nerve block and you've gotten good relief, but you don't get the long-term benefit, in certain cases, not all, that patient may be a good candidate for radiofrequency, where you go back in there and you create a thermal lesion, and that provides the patient with longer lasting benefit, anywhere from 3 months to 18 months of pain relief. Of course, your body's going to heal, and it's going to make that nerve come back, and so it wears off. That's good, and it's bad. It's good because if you ever have any kind of problem with that kind of procedure where you develop a neuritis or things get worse, it will go away. All right? It's bad in the sense that if you get 100% relief of the pain, you're going to be very happy, but it's going to wear off. All right? So it's a balance. Now, following that, you've gone through all that, and your pain's still there. All right? So that's when we get to the implantables. And we got essentially two types. You got the neurostimulator, and you have the drug delivery systems. All right? And neurostimulator essentially uses an electrical current, and the other one delivers a medication. I'm hoping I'm not in the middle here. You can see okay? Okay, good. And of course, there are also surgical interventions. If you have a herniated disc that is putting pressure on a nerve, there's none of these things that are going to help you. You will need a surgeon. There's no two ways about it. Also, something that happens common to most of us as we grow older, spinal stenosis. A lot of us, all of you guys have heard of that. Essentially, spinal stenosis is when the canal inside of your spine decreases in diameter. And that, of course, can lead to pressure over the nerves around it. As it decreases in size for a number of years, the main problem of pain, numbness, and weakness will be one due to swelling. And for those years, we can take care of those with medications, injections, things of that nature. Eventually, it can get to the point where the diameter of that canal is such that it's putting pressure on the nerve, even if we get rid of the swelling on that nerve. And that's when you need a decompression, and you'll need a surgeon on that one. You have some minimally invasive surgical interventions, kyphoplasty, vertebroplasty. Those are the ones that we use when there is a fracture on a vertebral body. Those fractures occur very commonly if you have osteoporosis. All right. Now, one of the things that you do need to know is that when you have a fracture, the pain that you get from a fracture is usually 2 levels below where the fracture is. So you may look at the physician. He may put, he's looking at your back on an X-ray. He puts your finger over it, says, "This is where you got your fracture." And you say, "Well, but I feel it lower." Yes, you will. That's kind of the way it is. Okay, that's where the pain is referred to. All right. Now, surgical therapies, well, you have your lumbar decompressions, laminectomy. This is what you do for that spinal stenosis. What you essentially do in a laminectomy is you take the roof out of that canal so as to allow for the nerves to breathe. And then fusions. Fusions are the ones that we nowadays have that very few insurance companies are paying for them. Fusions is what the surgeons used to use for patients with pain coming from the disc. Not because the disc is herniated or putting pressure on any nerve, but because the disc itself can be hurting. Now, the fusion, the theory is that if you fuse the segment and stop the movement, then the pain's going to get better. The problem is that very few people have problems with only one disc. Most people have problems with multiple discs. And if you were to have problems with only one disc, the chances of a fusion getting rid of your pain is only 50%. The more disc you have involved there, the less that fusion is going to help with that pain. Now, that's one type of fusion. There's another type of fusion. The fusion that you have when you have a laminectomy. Sometimes your laminectomy may be extensive. And if they take enough of that roof, you're going to destabilize the spine. And you're going to need a fusion to stabilize it. That's different. Okay? And that, of course, works better. All right. So when you're dealing with a neurostimulator and what you're using is an electrical current, what the therapy essentially what it is that you put an electrical device or a set of electrodes inside of the canal, and you initially do it through an epidural needle. And then you turn on the machine, and what it will do is it will create an electrical current. This electrical current is going to be over the posterior columns of your spine. This is the area where sensation is located in the spine, or where our sensory tracts are. So essentially what we do by establishing that electrical current there is we can disrupt that signal. So that when that signal of pain is coming from your leg up into your brain, as it goes through that area where I have the stimulator in, I can scramble that signal so that by the time it gets to your brain reads it or interprets it different. More like hopefully a soothing, tingling sensation. All right? And that's essentially how it works. Now in the stimulators, you can have them for the cervical region, where it gives you sensation and covers pain in the neck, the arms. You can also have it in the lumbar region, where it covers a certain degree of low back pain, but it's especially better for the legs. All right? And also we can put it in the occipital region for occipital headaches. All right? Now, benefits may include, or at least this is what we're looking for when we do a trial. In order for you to get one of these, there are certain things that you'll have to do. We'll have to get a medical psychology evaluation, and we do a trial. In the trial, what we look for is essentially getting 50% or better relief of the pain, less use of pain medication, and an increase in the amount of activity that you can do. Now, one of the beauties of this kind of therapy is that it's completely reversible. Contrary to a surgery where the surgeons go in there and you end up full of screws and plates and all that, you can't reverse that. Okay? But this, it's perfectly reversible. All you have to do is just go in there, pull the electrodes out, end of story. They're not attached to anything inside of the canal. All right? Other things that you should know, that the screening test is needed. And then basically we go into certain statistics here where Medtronic's indicates that they've had probably over 250,000 of these things implanted worldwide. One of the things that I like about the Medtronic's company is that they are worldwide. What does that mean? Well, if you happen to get into an airplane and go to Europe and you have a problem there, you can call a little card that they give you, and they'll set you up with somebody close by that can fix your problem. Risk. The risk of this type of therapy are pretty much the same as when you're having any kind of surgery. You can have infections, bleeding, nerve damage, things of that nature. Device complications that may require some surgery. If by any chance you can have migration, that's when immediately after you have the device put in, we normally ask you to just kind of take it easy for the first couple of weeks so that there is a little bit of scar tissue that develops around it and it keeps it from moving to the sides. If you go crazy and start doing stuff too early, then that thing can move from where we put it, and then you'll end up feeling something different. It'll be stimulating a different area than what we put it in there initially. You can have a loss of effect, meaning that some people can get used to the sensation. There are some studies that suggest that if you use certain medications like baclofen, actually it can help with minimizing that. You can have lead fractures, migration, dislodgement, and therapy that does not meet the patient's expectations. This is very important here. This is why you'll see that, I come in here today late, because I take time to talk to my patients, make sure that you have appropriate expectations. Because if I try to go in there and tell you we're going to be doing something that is going to completely eliminate your pain, well, you're going to be disappointed. And one of the things that I used to teach my fellows is a simple example. If you go ahead and take 2 patients and you do an epidural steroid on both patients, all right? And you tell one of the patients, oh, this is the greatest thing in the world, and this is going to give you 100% relief of pain. You'll need only 1 shot, and you'll be fine. All right? And then you take the other one, and you basically look at it and say, well, we've looked at what you have. It's pretty bad. We're going to try to do this for you. I'm hoping that you may get like 50% relief from this, but we'll do our best. Both patients come back and they tell you that they've had 75% relief. What do you think is going to happen with the one that you told him that he was going to get 100%? Oh, he's going to be disappointed, right? All right. How about the other one? He'll be thrilled. He'll tell you, Doc, you're the biggest thing or greatest thing. You got 75 more than you told me. So, unfortunately, this has to do with this, expectations. This is more of the art of pain management. All right? And you should, when you have pain that's been there for longer than 3 months, we have a very narrow window to really get rid of it. The rule of thumb is normally 1 year. If you have not gotten rid of that pain by the end of 1 year, it's very likely that's just the way it's going to be. All right? So sometimes I see patients come in with pain that has been there for 3 years. They say, oh, you need to get rid of it. Let's be realistic. Do you really think that's going to go away? I mean, I may be the greatest thing in my own mind, but the truth is that you do need to be realistic, and that's not going to happen. There's a lot of people out there that are very good, and they should have gotten rid of this a lot sooner if that was something that could be done. So that's why what we do is called pain management. We don't do pain elimination. We do pain management. All right? The other technique that we have is the pump delivery system. Okay, when do I use this in comparison to the neurostimulator? Well, the pumps have some limitations. And this right here is it. Pain that is from here up, a pump normally can't take care of that. Because the medication, you put it in the lower part of the back, and even though the normal flow of the fluid in which our brain and spinal cord float is upward, and it will take up some of the medication, it's not quite enough to control pain from about your chest up. So if you have problems with the neck, arms, stimulator is the only option you get. Pumps are pretty good if your pain is mostly axial. That's what I use. Meaning that your pain is more on the back as opposed to the legs. If when you come in to see me, I ask you, okay, tell me what's your pain like? How much pain do you have in your back versus your leg? And you say 90% in my back and 10% in the leg. Well, right there, if we were going to do something like an implant, a pump may be a better choice. And the spinal cord stimulators work well for pain in the back, but usually they're kind of limited from about this level down. Okay? So not so much when we're talking about the upper area. Pain between the shoulder blades, that's what we call no man's land. No man's land meaning that we really can't stimulate in there, and it's really hard to get the pump to deliver medicine in there. Besides, most of the time, the pain that you have between the shoulder blades, If you also have symptoms in the neck and the shoulders, it's coming from a C5 injury, meaning that it's an issue with your neck. All right? And it just turns out that the C5 nerve has some branches that essentially go to the rhomboid muscles, which are the ones in between your shoulder blades. The pump, we also do a trial with those. And again, we're looking for more than 50% reduction of the pain, using less medications by mouth. And of course, the pumps, what they have is that they're much more sophisticated in terms of the way that we can program them. We can change the concentrations on the pumps. We can put different kinds of medicine in there. We can put local anesthetics in there. We can put narcotics. We can put clonidine, which is a medication that is used for neuropathic pain, but it's also a blood pressure medicine. We can use a number of things. Now, some of them, I have to remind everybody here that they may not be FDA approved. And that's what we call off-label use of the medication. And that's something that you just have to talk to your patient as you're planning on doing this. But some of those medications can be very helpful, like, for example, local anesthetics. Although the local anesthetics are not FDA approved to be used in the pump, all right, we've used them in anesthesia for years. And we know that they're safe. And I have pumps, I've had pumps that, you know, I've used local anesthetics for to help control the pain. It's a nice option because it's a numbing medicine, so it has very little in terms of side effects. Okay, yes, it can numb you. Yes, if you use too much concentration, it can give you a little bit of weakness, but it's not like the narcotics that can give you respiratory depression, kill you, that kind of thing. All right? So, again, this kind of therapy is also reversible. All right? And that's also nice about it. Other things that you should know, that there's a trial for that. The trial, every pain physician has their own book on how to do the trial. The way I do mine, I bring the patient into the hospital for 3 days and I do 3 separate spinal injections. All right? And during those 3 days, I will use 2 of the days you're going to get the active ingredient, meaning either morphine, Dilaudid, any active medication. And 1 day, which I'm not going to tell you which one it is, you're going to get just plain old sterile water. Why do I do that? Because I want to know if the relief is coming really from what we're injecting or from your mind. And not that you're making it up, but our minds can be pretty strong in terms of that. And in fact, one little detail that you should all know, if you ever see any kind of therapy that they offer you and they tell you that it has a good solid 30% success rate, that thing doesn't work. Because 30% is placebo. No matter what you give a patient, you can give it sugar, 30% of the patients will feel better. Okay? So any kind of therapy that they try to sell you out there with 30%, that ain't working too good. 40, On the other side of that spectrum, if they come back and they say, oh, what we're going to do here is going to give you great relief of the pain, and you know, chances of you getting better are upwards of 80%. I've had that. I've gone to physicians for my sons and stuff like that, where, you know, eye correction and other things. But anyway, when they told me that, I said, well, thank you very much. I turned around and I left. Because they're not telling you the truth. Even if you're the greatest guy in the world, what is always going to happen is that the better you are, the more difficult cases are going to come to you. And you will have to fail. You have to fail because nobody is perfect. So 80% is damn good. All right? Anything above that, they're telling you a story. All right. So, and again, with pumps, there are less of them out there, but still, it's pretty good therapy. How long do they last? A pump may last about 5 years, the battery in it. Okay? And after 5 years, you come in, a little bit of local anesthetic, you open up, take the old pump out, disconnect the tube, connect it to the new pump, put it back in there, you're done. All right? How do you refill this pump? You refill it through your skin, and you also reprogram it through your skin. You don't have to come in and have a big procedure done every time that you're going to reprogram it. It's a simple thing to do. And I have some wonderful nurses back there that are the ones that do that for me. All right? Hey, you owe me now. All right. And how about the spinal cord stimulator? Similar. The spinal cord stimulator, you have choices. You can either have one in there that you can recharge yourself, or one that doesn't need to be recharged. Now, when we do the trial, we'll give you some guidelines as to which one you should use, based on how much energy you're requiring to control your pain.